Welcome to This Week in Neurosurgery. This week we're covering 10 notable papers spanning acute neurotrauma and stroke systems of care, cranial nerve and skull-based surgery, and outcome prediction in cranial and spinal practice. Let's dive in. We start with time, triage, and the systems around the acutely injured brain. In World Neurosurgery, Shan and colleagues report a retrospective multicentre cohort of 726 adults with aneurysmal subarachnoid hemorrhage across 7 comprehensive stroke centers in China, comparing those who reached an endovascular-capable hospital within 8 hours of symptom onset against those who arrived later. After adjustment for age, Hunt-Hess grade, modified Fisher grade, and other confounders, delayed arrival was associated with roughly a 5-fold increase in the odds of a poor functional outcome at 6 months, and about 2.5 times the odds of death by 12 months. Delayed patients also had more brain herniation, hydrocephalus, ischemic stroke, and rebleeding. This is observational, and the possibility that sicker or more remote patients simply take longer to arrive is hard to fully exclude, but the 8-hour mark is a concrete, auditable target for regional stroke network design, and it argues for direct routing to endovascular-capable centers rather than sequential transfer. Alongside that, the Journal of Neurosurgery Pediatrics brings a prospective cohort of 425 children with non-penetrating traumatic brain injury, in which Reisner and colleagues measured a panel of blood biomarkers within 24 hours of injury and asked whether they predicted the need for neurosurgical intervention. About 1 in 7 children underwent craniotomy, craniectomy, external ventricular drain, or intracranial pressure monitor placement. All the biomarkers were higher in that group, but after controlling for age and admission Glasgow Coma Scale score, glial fibrillary acidic protein stood out, with an area under the curve of 0.83, discrimination that held independent of the clinical variables we already use. This is proof of concept from a single tertiary center, not a triage algorithm ready for deployment, but it is the kind of data that will push pediatric biomarker thresholds into future guidelines. Staying with severe head injury, World Neurosurgery published a prospective multicentre randomized controlled trial from 2 Malaysian hospitals that takes aim at a reflex habit, indefinite proton pump inhibitor prophylaxis, in the intensive care unit. Selvam and colleagues enrolled 145 patients aged 12 and over with severe traumatic brain injury and a Glasgow Coma Scale score of 8 or less, gave everyone a proton pump inhibitor while nil by mouth, and then randomized them once enteral feeding was established and tolerated to feeding alone or feeding plus continued prophylaxis for 5 days. There were no clinically important gastrointestinal bleeds in either arm. Overt bleeding occurred in 3 patients on feeding alone and 2 on feeding plus the proton pump inhibitor. No meaningful difference. Daily mean intragastric pH stayed above 5 in both groups throughout. The honest caveat, which the authors state plainly, is that this is a 5-day observation window and a modest sample, so longer-term safety is unaddressed. Still, for a practice driven largely by inertia, this supports stopping the proton pump inhibitor once feeds are running, and reducing the downstream pneumonia and Clostridioides difficile exposure that goes with prolonged acid suppression. The second theme is cranial nerve preservation and skull-based technique, where 2 papers on vestibular schwannoma land in the same week from different journals, with a genuine strategic disagreement between them. In the Journal of Neuro-Oncology, Leo and colleagues report 146 patients operated by a single surgeon using a subperineural onion peeling dissection that leaves a thin layer of perineurium over the facial nerve as an anatomic buffer, with mean follow-up close to 7.5 years. They achieved House-Brackman grade 1 or 2 facial function in about 95% of patients, while removing at least 95% of tumor in over 97%, with a cerebrospinal fluid leak rate under 3% and recurrence in about 3%. Their argument is that the fashionable alternative, planned subtotal resection followed by radiosurgery, trades a larger residual and irradiation exposure for a facial nerve benefit that maximal safe microsurgery can deliver anyway. Set that against the Journal of Neurosurgery paper from Kalegi and colleagues, a decade of multidisciplinary practice across 187 patients and 3 standard approaches. Favorable facial nerve function reached about 87% at long-term follow-up. Gross total resection was achieved in about 2/3 of cases, and serviceable hearing was preserved in around 42% of patients when preservation was attempted. Their contribution is predictive. the presence of fundal cerebrospinal fluid space roughly tripled the odds of good early facial outcome, and predicted better results, specifically in retrosigmoid cases, while heterogeneous contrast enhancement predicted worse facial outcomes in translabyrinthine cases. Notably, surgeon learning curve stage was not associated with overall facial nerve outcomes in a multidisciplinary team setting. Read together. The message is that preoperative magnetic resonance features should inform which approach you choose and what you promise the patient, and that the case for planned subtotal resection is weaker than its popularity suggests in high-volume hands. Also in the cranial nerve space, World Neurosurgery reports 200 consecutive endoscope-assisted microvascular decompressions for hemifacial spasm from Lee and colleagues, using the endoscope to inspect the neurovascular relationship before and after microscopic decompression. Complete spasm resolution reached 92% at a median follow-up of 20 months, abnormal muscle response disappeared intraoperatively in about 92%, and permanent facial weakness and permanent deafness were each in the low single digits. No complication was attributable to the endoscope itself. This is a single-arm series without a microscope-only comparator, so it establishes feasibility and safety rather than superiority, but it makes the hybrid workflow hard to argue against on safety grounds. Our third theme is where established surgical dogma meets contemporary outcome data. The Journal of Neurosurgery publishes a deliberately provocative reassessment of supplementary motor area syndrome from Dano and colleagues, reviewing 80 patients who underwent dorsomedial frontal resections over 2 decades. New postoperative motor deficits occurred in about a third of patients, but once cases involving the primary motor cortex or cingulate gyrus were excluded, the incidence of true supplementary motor area-specific deficit was only 10%. More than 4 in 5 new deficits resolved at a median of 13 days, and permanent deficits occurred in about 6%, those tied to preoperative weakness and major postoperative complications, rather than to the extent of supplementary motor area resected. There was no association with intraoperative mapping use or with the percentage of supplementary motor area removed. The authors' claim is that persistent deficits reflect injury to adjacent eloquent structures, not the supplementary motor area itself, and that with navigation, gravity-based retraction, and modern mapping, this region can be approached more aggressively than tradition allows. In the same journal, Halal and colleagues report 26 consecutive patients undergoing nerve root ligation for cerebrospinal fluid venous fistulas, causing spontaneous intracranial hypotension. Nearly 85% improved symptomatically, 94% improved on the Burns score, and about 83% returned to work, with a single patient developing radicular pain needing further intervention. Preoperative Burns score correlated with both outcome and quality of life, a usable preoperative selection tool in a disease we are still learning to treat. 2 papers round out the week on perioperative decision-making. In neurosurgery, Gauhar and colleagues reviewed nearly 2,000 craniotomies at a center with an institutional postoperative systolic target below 140, comparing patients who required intravenous nicardipine against those who did not. After propensity weighting, nicardipine exposure was associated with about a third higher odds of a composite of acute kidney injury, troponin or natriuretic peptide elevation, stroke or death, and with hospital stays roughly a day and a half longer. This is retrospective and confounded by indication. Needing nicardipine marks a sicker, more hypertensive patient, but it should at least prompt scrutiny of reflexive sub-140 targets after tumor craniotomy. And in the Journal of Neurosurgery, Spine, Hannon and colleagues analyzed a prospective registry of 1,713 anterior cervical spine patients using the eating assessment TOOL-10. Revision surgery for adjacent segment disease did not raise baseline dysphagia rates, but it independently predicted dysphagia at 3 months and slower recovery in patients who came in already symptomatic. Within revision cases, baseline dysphagia, C3-4 exposure and re-exposure of prior levels raised risk, while an otolaryngologist-assisted approach lowered it. 3 concrete things to say in the consent conversation. If you only have time for 1 paper this week, make it the randomized trial on stopping stress ulcer prophylaxis once enteral feeding is established in severe traumatic brain injury. It is the only randomized evidence in the set, and it directly de-implements a daily habit in almost every neurosurgical intensive care unit. Here are the key takeaways from this week in neurosurgery. First, Once your severe head injury patient is tolerating feeds, the proton pump inhibitor can likely come off, at least over the first 5 days. Second, reaching an endovascular capable center within 8 hours of subarachnoid hemorrhage onset should be a network-level target, not an aspiration. Third, in vestibular schwannoma, maximal safe microsurgical resection with meticulous subparaneural dissection delivers excellent facial nerve outcomes, and preoperative magnetic resonance features, especially fundal cerebrospinal fluid space, should guide your approach selection. Fourth, supplementary motor area syndrome, as classically taught, is likely overstated. Deficits that persist usually reflect injury to neighboring eloquent cortex. And fifth, be deliberate rather than reflexive about tight blood pressure targets after craniotomy, and counsel revision anterior cervical patients that swallowing recovery will be slower. That's your roundup for this week in neurosurgery. The full transcript and references are available on the episode page in your AudioScholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And think of one colleague, in any specialty, who never has time to keep up with the literature. Tell them about AudioScholar, a free 10-minute weekly for every specialty, to listen to in any podcast app, or to read at audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.